Assalamu alaikum. It's a long gone. I haven't made any video. Today I would like to discuss about the third part of this series, Gastroenterology series, regarding 10 page at a row, and try to discuss in a simplified manner. Start with this CDH, congenital diaphragmatic hernia. What happens in congenital diaphragmatic hernia? There is incomplete fusion of the pleuroperitoneal, incomplete fusion of the pleuroperitoneal fluid fold, incomplete fusion of the this pleuroperitoneal fluid fold, and there is herniation of the bowel into the chest. Herniation of the bowel, this is into the chest. There is pulmonary hypoplasia, lungs becomes narrowed, uh, and there is pulmonary hypertension. So incomplete fusion of the pleuroperitoneal fluid, herniation of the bowel into the chest, and pulmonary hypoplasia. Clinical feature is respiratory distress like tachypnea, cyanosis, and retraction. Within hours of birth, there is a tachypnea, cyanosis, and retraction within hours of birth, and there is absent breath sound, ipsilateral to the defect. Where there is defect, there is absent breath sound, and concave abdomen, barrel shaped chest. If you look at the chest, there is a barrel shaped and the abdomen is concave shaped. Chest X-ray is intrathoracic bowel lobe, displaced cardiac shallot, displaced cardiac shadow. Management is endotracheal intubation, gastric decompression, NG tube, and surgical correction. Endotracheal intubation, gastric decompression, and surgical correction. Protrusion of the abdominal content through the defect. Protrusion of the abdominal content through the defect, most commonly left-sided, into the thoracic cavity, compromises lung development, leading to pulmonary hyperplasia and causing deviation of the heart, into the right thorax, There is right-sided heart sound. As the heart is deviated, as the lung is hypoplastic, heart is deviated to the right thorax, and right-sided heart sound. In utero, remodeling of the pulmonary vasculature also leads to arterial musculature hyperplasia and persistent pulmonary hypertension. Chest X-ray is diagnostic in CDH, that is not detected prenatally. This is not detected prenatally. Lack of uh, prenatal care. The first steps of CDH is endotracheal intubation. Mechanical ventilation should be used cautious with limited pressure to avoid barotrauma to the hypoplastic lungs. Lung is hypoplastic, so barotrauma may happen. So mechanical ventilation should be given in a cautious manner. A bag and mask ventilation is contraindicated. Bag and mask ventilation is contraindicated because it pumps air in the GI tract, leading to further lung compression. In addition, a gastric tube should be inserted and connected to continuous suction to prevent bowel distension. Surgical correction is a definitive treatment. This is the congenital diaphragmatic hernia. This is IT tube. This is IT tube or chest tube. This is also the chest tube. In here there is fundus. This is the fundus. This is NG tube. This is NG tube. NG. So NG tube, chest tube. This is chest tube. NG tube, chest tube. Also this is a chest tube. This here is the greater curvature of the stomach. So herniation of the gastric content into the thorax. There is herniation of the gastric contents into the thorax. Then next, the paraesophageal hernia. In paraesophageal hernia, there is retro. Retro means backside. Retrocardiac, backside of the heart. Retrocardiac air fluid level due to stomach bubble within the thoracic cavity. Due to stomach bubble within the thoracic cavity suggests paraesophageal hernia. Although it may also be seen in sliding hernia, the diagnosis is confirmed with barium swallow and upper endoscopy. Whereas a symptomatic sliding hernia is generally managed with medical treatment and reflux symptoms. Sliding hernia occur due to laxity of the phrenoesophageal membrane, typically in the setting of age-related degeneration of repetitive stress, vomiting, and coughing. These allows the gastroesophageal junction and the proximal stomach to slide into the thoracic cavity. These slides into the thoracic cavity. What are the things slides into the thoracic cavity? The GE junction in the proximal stomach. Most sliding hernias are discovered incidentally during imaging performed for other reasons. Plain radiography typically reveals this retrocardiac opacity, often with an air fluid level within the thoracic cavity. Asymptomatic. It is asymptomatic, require no further evaluation beyond observation. Patient with reflux symptoms should be medically managed with PPIs, proton pump inhibitor. Those with refractory GRD symptoms can be considered for anti-reflux surgery, like Nischen's fundoplication. Also, patient may have dysphagia, but regurgitation of the undigested food is typical. This is the hiatal This is the picture of the hiatal hernia. There is air fluid level. This is the air fluid level. The contents gastroesophageal junction and other contents herniates. Femoral hernia risk factor: chronic cough, constipation, and smoking. Most cases arise in older women and presents as a non-pulsatile mass. It's not pulsatile because in here there is no arterial supply. Below this there is no arterial supply. So in femoral hernia, there is non-pulsatile mass in the groin. The mass generally worsens with increased abdominal pressure standing. These mass worsen when you stand, when you do balsal, when you cough. Improves with decreased abdominal pressure, like lying and seeing in the sky. This relieves the pressure. When you stand, when you start working, calm it will cause pain. When a bowel loop is present within the hernia, it is tympanic to percussion. When there is bowel, in bowel there is gas, and the gas causes tympanic on percussion, because in pneumothorax, tension pneumothorax, and other pneumothorax, there is tympanic on percussion. Why? Because air in the lung, in here, air in the bowel, that causes tympanic to percussion. The presence of fullness or tenderness within the right groin suggests the SBO. SBO. That means small bowel obstruction is due to incarcerated hernia or groin. Because femoral hernia pass through a narrow orifice, they are associated with substantial risk of incarceration, which may lead to small bowel obstruction and strangulation. Therefore, asymptomatic femoral hernia are generally referred for elective surgical repair to prevent potentially life-threatening complication and subsequent high-risk emergency surgery, which is associated with increased risk of obesity, bowel resection, and mortality. In contrast, inguinal hernia above the inguinal ligament are associated with a lower risk for incarceration. That means incarceration and strangulation. Because hernia contents pass through a wider surface, therefore most asymptomatic inguinal hernia can be managed with reassurance and watchful warning. Femoral artery aneurysm is associated with pulsatile groin bulge that does not change with the alteration in the abdominal pressure. CT angiography is done to diagnose groin abscess. Usually have fever, warmness, and erythema and tenderness. Rectus sheath hematoma seen with blunt trauma or forceful abdominal contraction, that is severe coughing and asthma exacerbation, particularly in patient receiving anticoagulant therapy, anticoagulation therapy. Older age, female sex, acute onset abdominal pain with palpable abdominal mass, blood loss, anemia, leukocytosis may happen. Nausea and vomiting, fever can happen. In hemodynamic stable patient with rectus sheath hematoma, serial monitoring of the CBC, reverse anticoagulation and transfusion of blood product when appropriate. In unstable angiography with embolization and surgical ligation. In case of unstable rectus sheath hematoma, in hemodynamically stable, there is serial monitoring of the CBC, reverse anticoagulation. Rectus sheath hematoma typically occurs due to rupture of the why it happens due to rupture of the inferior epigastric artery, which supplies the blood to the lower aspect of the rectus abdominis muscle. Lower aspect of the rectus abdominis muscle is supplied by inferior epigastric artery. If this artery gets cut, if this artery gets injured, these may cause rectus sheath hematoma. Manifestations include acute abdominal pain, palpable abdominal wall mass. Tenderness may worsen with abdominal contraction. This is carnate sign. You get the carnate sign in rectus sheath hematoma. So in rectus sheath hematoma, what happens in here? We know that rectus sheath, the lower part of the rectus sheath is supplied by inferior epigastric artery. If it is cut down, if this injured, if this artery is injured, then this may cause rectus sheath hematoma. It may present with abdominal pain or palpable abdominal wall mass and tenderness. With worse tenderness may worsen with abdominal contraction. If there is abdominal contraction, the tenderness may happen. Foreign body. If you find a baby ingesting foreign body, suspected foreign body injection, PL lateral view, CT scan, PL lateral view, CT scan. If object not visualized on X-ray, if high risk, endotracheal removal. If no risk feature, serial X-ray. If no risk feature, serial X-ray, and If high risk endoscopic removal, if no high risk, there is serial X-ray, no transit, endoscopic removal, other object moving distally, no intervention, object moving distally, no intervention should be done. So suspected foreign body ingestion, PA lateral view, if the object not visualized, do CTs. If it is high risk, endoscopic removal. If it is low risk, serial exit should be done, no transit. Endoscopic removal and occult immediate endoscopic removal should be performed in the following circumstances. Sharp object. If needle or safety pin is entered into the esophagus, stomach, or duodenum, endoscopic removal should be done. If symptoms of esophageal obstruction like drooling, inability to swallow secretion, if there is a respiratory compromise, like if there is button butter in the esophagus, degree risk of electrical or chemical injury, if there is magnet in the esophagus, magnet, button battery, needles and safety pin, if there is esophageal obstruction, respiratory compromise, immediate endoscopy should be done. If a sharp foreign body is distal to the proximal duodenum in an asymptomatic patient, observation with repeat X-ray in 12 to 24 hours may be appropriate because these objects are usually excreted unevenly. Magnets are identified beyond the stomach and can be removed via colonoscopy, or followed by serial X-ray every 4 to 6 hours. If symptoms abdominal pain, gastro, GI bleeding develop on the margin of develop on the margin, surgical removal should be done. Although ingestion of the surgical magnet may cause bowel entrapment, observation and serial imaging can be considered because of relatively lower risk of complication. Observation is contraindication in patient more than two or more esophageal magnets due to risk of necrosis and perforation. There is an increased risk of necrosis and perforation, so observation should not be done. Barium esophagography may be performed several months after ingestion of the corrosive agent cleaning product to assess for stricture formation. Contrast is avoided in acute management of the foreign body ingestion because it can obscure and visualization and hinder removal of object. Radiographic feature that distinguish a bilaminar structure, a button battery from a flat coin, a hollow or double ringed circular object in the AV view, a hollow or double ringed circular object in AV view, a step off or beveled edge on the lateral view. Emergency endoscopic removal is the treatment for esophageal button battery. Administering Anisin for ingestion in an asymptomatic patient may provide a partial protective barrier because it should not delay the definite punishment. Treatment delay increases the risk of late complications like especially stricture and stenosis. So if there is a foreign body in the esophagus, treatment should not be delayed because complication may happen. It may cause stricture. Uh, an asymptomatic patient who ingested a small blunt object one may be observed or repeat X-ray after 24 hours to confirm the progression of the object beyond the stomach. This is a quant seen on the lateral X-ray chest. In such cases, you should do repeat X-ray to look. Sorry, this is the picture of a battery. This is a picture of battery. This is trachea. This is trachea is informed, and the esophagus. In here there is a button battery. So these should be removed endoscopically. Endoscopic removal should be done in such cases. Pain and obstruction like shingles, common thing. Patient experience pain and vesicular rash in the dermatomal distribution. The pain may precede the rash, but several days during which the diagnosis may not be apparent. Shingles may occur at any age, but it is the most common after age 50. Shingles is the most common because now small bowel obstruction is the common cause of abdominal pain, but it most often occurs in patients with adhesion prior abdominal surgery. Small bowel obstruction. There is colic abdominal pain, vomiting. There is colic abdominal pain, vomiting, inability to pass flatus or stool. Inability to pass flatus or stool if complete. Inability to pass flatus or stool if incomplete. No abstupation is partial. There may be hyperactive absent bowel sound when ischemia. There is distended and tympanic abdomen. Diagnosis is dilated loops of bowel with air fluid level. Dilated loops of bowel with air fluid level on plain or CT scan. Partial is air in the colon and complete is transition point, no air in the colon. Transition point, abrupt cutoff sign, no air in the colon. Complication ischemia, necrosis, there may be bowel perforation. Management bowel rest, nasogastric tube suction, IV fluid, and surgical exploration for complete obstruction and signs of complete obstruction, surgical exploration for complete obstruction and signs of complication. Changes in the character, fever, hemodynamic instability, guarding leukocytosis, and significant metabolic acidosis may be seen. Small bowel obstruction, it is a colic abdominal pain, vomiting. It's a colic, abdominal pain, vomiting, inability to pass, flatus or stool. If complete, inability to pass, flatus or stool. If complete, no obstipation. If partial, hyperactive initially, and absent bowel sound when ischemia distended and tympanic abdomen is seen. Diagnosis is dilated loops of bowel with air fluid level on plain CT or scan. Partial is air in the colon, incomplete is transition point, abrupt cut-off sign, no air in the colon. No complication is ischemia necrosis, and there is a bowel perforation. Management is bowel rest, nasogastric tube suction, IV fluid, surgical exploration, complete obstruction, and signs of complication. And that's all about small bowel obstruction. Hope you enjoyed.